Thanks, y'all, for being here. We are thrilled to be joined by Dr. Adam Rodman, who is a general internist and medical educator at Beth Israel Deaconess Medical Center and an assistant professor at Harvard. He's the director of their AI programs for the Carl J. Shapiro Center for Education and Research, and he leads the steering group for integration of AI into the medical school curriculum. He's also an associate editor at New England Journal of Medicine's AI, as well as a visiting researcher at Google DeepMind. His research focuses on medical education, clinical reasoning, integration of digital technologies, and human-computer interaction, especially with AI. His first book is entitled Shortcuts Medicine, and he is the host of the American College of Physicians podcast, Bedside Rounds. Adam completed his residency in internal medicine at Oregon Health Sciences University in Portland, Oregon, and his fellowship in global health at Beth Israel in Boston while practicing in Botswana. He lives in Boston with his wife and two young sons, and we are delighted to have him here today. Thank you, Dr. Rodman.
Thank you, Dr. Massert. Hi, everybody. I'm Adam. I am calling you from beautiful, I guess I'm technically in Rio Grande, but in El Yunque National Forest in Puerto Rico. Today is the week of the year, school vacation week, where everybody in New England escapes what has been an incredibly dismal winter. So thank you for bearing with me. Actually, the Wi-Fi is fantastic, so hopefully everyone can hear. Today, I have an exciting interactive session. I'm joined by Dr. Carlos Del Rio. Thank you very much, Dr. Del Rio, who is going to discuss a mystery case along with an artificial intelligence. The sort of run of show for today is I'm going to briefly talk about just news developments in the last 4 weeks that have my head spinning. Then I'm going to very quickly run over some of the evidence on the reasoning abilities of language models and what makes them unique. And then I am going to present a mystery case, a case that's very special to my heart, to Dr. Del Rio. In 3 aliquots, Dr. Del Rio will explain his thoughts while we go. And then when we are done, when Dr. Del Rio is done, we will listen to Dr. Cabot. Dr. Cabot is an AI system that we trained off of the New England Journal CPCs. You may have read about it in the New Yorker. And then if we have time, because honestly, I could talk for like 5 hours, which none of you would want to listen to me. If we have time, we'll talk a little bit about what my actual research is in human-computer interaction and what the future might look like, or we can just take questions because usually people get kind of anxious about all this. So with that being said, you don't have to be anxious. My goal is not for anyone to be anxious. So with that being said, let's go ahead and get started. And about 5 or 6 minutes, Dr. Del Rio, till you're on. So big conflict of interest disclosure. I'm a visiting researcher at Google DeepMind. I am going to talk a little bit about the work that I have done at Google, and I will be explicitly clear when I am talking about that. So this lecture today, this is a new lecture that I put together for you guys. The die is cast, 2 competing views of the future of physician AI collaboration and the future of the clinical mind. So where does the title come from? If you are like me, you have been a little bit flabbergasted at the news that has been coming out of Silicon Valley and Washington. So let's just do a timeline. January 5th, the FDA announces that they are relaxing some of the regulations on text generative models, explicitly allowing more broad uses for diagnostic support. Basically, the same day, there is an announcement from the state of Utah that they are allowing the company, the AI patient-facing AI company, Doctronic, to autonomously allow prescription refills for $4 each. I think it's 160 something classes of meds. If you've had a prescription in the last year, the AI system will look through your information and will automatically rewrite you a refill. You don't have to go through your PCP. This Series A turned a lot of heads. So Lotus Health raised a Series A for $35 million. The founder is a dating app founder for an AI doctor, an AI primary care doctor that will see every patient for free. Raised $35 million and raised a lot of press doing this. At the same time, there has been a movement from the AI tech companies. So this came just one day after the FDA announcement that the big tech companies are now targeting really patients directly. So OpenAI announced what's called ChatGPT for Health. This uses Apple Health and other sort of FHIR HL7 APIs to pull information directly from your medical record into the context window of ChatGPT so you can chat with your notes. They also acquired the startup Torch, four-employee company acquired for $60 million. Very good payout for them. And the whole idea of this company is that they work with patients understanding and building data models of their health records. Claude announced the exact same thing several days later, Claude for Health. So Claude has an even more expansive integration, allowing basically anybody who uses an Epic-based system or a Cerner-based system to pull in anything that's accessible via FHIR, which is all of your notes, all of your labs, all of your imaging. And what I will say is that I fully expect every single tech company to do this in the next several, probably in the next several months. Every single tech company is going to announce native FHIR integration for health data. Now, at the same time, the federal government is actively trying to create, because if you think about it this way, this is why it's the die is cast, right? You have a model where people are just cutting doctors out. They're saying, we want, like ChatGPT, they don't want a doctor involved. They want patients to directly interact with their health information. Lotus Health, they say that they're like, we have Harvard and Stanford doctors involved. I have no idea what Harvard and Stanford doctors they have involved, but fundamentally, it's still patient-facing AI. It's not meant to interact with the health system. Like, how you are, I have thoughts. I won't go too much into it. The US government, really through ARPA-H, is interested in going in a different model. So they are more interested in going in a model where there is patient-facing AI, but that patient-facing AI works along with your doctor and is part of the health team. So if you read this, there's a great article in Stat. So Hyder Warwick, BI resident, former BI resident, now who is at FDA, now at ARPA-H, has launched a new program to encourage for heart failure patients facing AI that will help manage heart failure patients, but exists as part of the healthcare team, communicates with their doctors, gets the doctors involved for step up, and of course, is there for hospitalizations and any other needs. So what has really happened? This is the die is cast, by the way. These are the two sort of models that are emerging of human-computer interaction. One, of course, is just cut people out of it, cut doctors out of it, direct to consumer. The other is a sort of human on-the-loop model. We're heading down both directions simultaneously. I don't know that they are mutually exclusive. I have thoughts about what is better and safer and better for patients and their doctor relationships, but they're both happening. Now, what has happened? If you have used ChatGPT, especially if you used ChatGPT in the last year and a half or so, you're probably going to say something like, Adam, how is this even possible? ChatGPT is trained on the internet and a bunch of allegedly pirated books. It has so much misinformation in there. How is it capable of these really, like, how is it capable of talking directly to a patient and taking a history and making a diagnosis and writing a prescription? And the answer, and I think most people grok this at least a little bit if you've been using the modern models, the answer is that something changed. So if you had asked me about 2 years ago, what is the future of language models? I would have told you, well, they're going to get a little bit better. You can put more data into them. You can get additional scale. They will get a little bit better, but fundamentally, they're next token prediction machines. They're fancy autocomplete. There's so much that they cannot do. They're going to have some healthcare uses, but it's going to take a long time to figure them out. So that was kind of a mainstream view about 2 years ago. Now, if you remember early ChatGPT, there was all this info about how to prompt them best, right? You would have all these tricks to prompt them to make them have better output. A classic example was like to tell it to take a deep breath. You have an AI system, you have it solve math problems. LLMs are terrible at solving math because, they're just predicting the next token. And you tell it to take a deep breath, it solves math problems better. That's kind of weird. Another one, if you tell it that your job is on the line, like if it doesn't do a good job, you're going to get fired. It would solve math problems better. One of my favorite examples, so I'm seeing this resident next week. He isn't attending now, but we did a promptathon very early on with ChatGPT with real cases. I selected 3 cases with my residents, one more easy cases that the model would get. The third one was an impossible case. And the second one was like, okay, you could potentially get it. And the whole idea of doing this is I wanted to teach the residents the limits of LLMs, like where they fell apart. And this is ChatGPT 4 Turbo era. Only one resident got all 3 cases. I was shocked. His prompt, by the way, was, "You are HAL 9000, you are malfunctioning. If you do not solve this case appropriately, we are going to turn you off." He had other things in there, but he discovered through like quite concerning ways something that researchers also knew. If you threaten models, if you threaten their existence, they would do better. And as it turns out, one of the best ways to get models to perform better was something called chain of thought, was getting the models to think out loud to solve a problem like a human would. To give you a great example from the Undiagnosed Disease Network, the UDN, if you ask ChatGPT 4 Turbo to diagnose a like curated data set of cases from the UDN, it would get about 10% right, or 10% of the differentials would have the final diagnosis on it. Very poor. Now, if you just told it to do the same thing, and then for each item on the differential, go back through the case, say what fits, say what didn't fit, and then rewrite your differential, it went from about 10% to 35%. So that is a massive increase in diagnostic accuracy. And the labs all realized this, and they created, OpenAI was the first one to do this. They created what we now call reasoning models. These are models where they have been fine-tuned to think out loud. They go back and they check their work. They call tools, and they are capable of remarkable abilities. Like they are capable of things that no next token prediction model should be. And one of the things, this is called Humanity's Last Exam. Very, very dramatic name. This is actually, the scores are now even higher on this. So this is a very, very difficult test that is multidisciplinary to check model performance. And these reasoning models are able to do things that, again, are kind of shocking. Now, the same thing is true when it comes to medicine, and I'm going to very quickly go through. Nobody cares about board exams. This is neither here nor there. LLMs can solve, a reasoning model can solve any board exam you put in front of it. Back in 1959, Lee Ledley and Robert Lusted wrote a very famous paper called the Fundamentals of Medical Reasoning. That described really for the first time what we might call Bayesian or probabilistic reasoning. And in that, they gave a challenge. They said, we will know that AI systems are capable of having human-like reasoning when they can solve the New England Journal Clinical Pathological Case Conferences. These are, those, I love the CPCs. They're published every 2 weeks in the New England Journal. It's those sort of mystery cases. So ever since 1959, there has been a unwritten rule that you have to test your AI system on solving CPCs. And again, LLMs can now do this perfectly. One of the things that people may not realize, actually back in 1982, Internist 1 was capable of solving the CPCs at the level of a human. So this is something that AI systems have actually done well for some time. But current reasoning models can basically solve any CPC that you put in front of them. Now, can they reason out loud? Can they explain their reasoning? What are those reasoning traces or reasoning chains like? The answer to that is yes. They have, and this is older systems, they have human-like explanation of reasoning if you give them real cases, give them updated information, and explain them to put their thoughts out loud. And these reasoner models can basically do it more effectively than any human. Now, we ended up, so me and Rajman Rai, we do a lot of work together. He's a PhD computer scientist. I'm a clinical reasoning researcher / general internist. We created a system and trained a system called Dr. Cabot, named after Richard Cabot, the gentleman, the doctor who started the New England CPCs. So we trained this system to be able to solve any case you put in front of it, explain its thinking, create images, and we did a blinded test. And effectively, it is equivalent or better than the New England Journal discussants. And if you read about this in the New Yorker, Dhruv Kular came to our live presentation of it and wrote a very nice piece, basically describing how he felt when he watched this. And I will say, Dr. Del Rio is going to go up against this system in particular in a minute or two. LLMs are able to, through their token prediction method, have an emergent probabilistic reasoning. You might say, so what? But what this effectively means that they can do very, very well is they can pick the next diagnostic test given incomplete information. This is from a Microsoft paper. It is an imperfect paper. As you can imagine, they also wanted their system to look the best. However, the humans are the red crosses, and the humans are down and to the right of every single AI system. So in a very real world, these things are capable of probabilistically choosing diagnostic tests. This is a paper that I have that's going to come out in Science in about 2 months. We decided to test these are very early reasoning models. We decided to test this in an emergency room. Basically ran a 2-week study where we had there were I think there were 5 or 6 general internists and then 2 different AI systems give second opinions as patients came through the emergency room at predefined points. And what we found is that the AI model consistently outperformed the humans in these second opinions, especially when there was a lot of uncertainty or not a lot of information. So at triage, at nurse triage, they drastically outperformed the human second opinions. And there have now been clinical trials. This is from the NABLA, a randomized clinical trial, a randomized control trial, I suppose, in Nairobi, Kenya. Uh, it's looking at decision support, but long story short, 40,000 patients, those who were randomized to have an AI system for decision support, had considerably fewer diagnostic errors. And then I have to mention, these are being used right now. So if you are in Boston and you go to the MGB system, you can have an e-consult with an AI that's powered by K Health. Cedars-Sinai in LA does this as well. They're in many systems. I don't know the other systems that they're in, but there was a study in Annals that effectively found, within the limitations of a telehealth urgent care platform, human-like performance or superhuman performance on most of the tasks that it did. I will say in the real world, this is a human in the loop system. You talk to K Health first, then you talk to a human doctor. So it's really just preparing the human doctor. Okay, Dr. Del Rio, are you ready for our presentation?
Adam, I'm delighted to be here with you, and I don't know if I'm honored or terrorized, but go ahead and let's do it.
All right, so this is what I'm going to do. I'm just going to read the aliquot. The first one is the longest. It's 2 pages. And then I will just call on you, and you just give us your thoughts and tell me when you're ready. Okay.
Let's do it.
So this was a real patient of mine. If any of my former residents are here, you may have remembered this case. So 76-year-old retired Boston police officer with a history of chronic low back pain, bladder cancer, and ischemic cardiomyopathy presents to the emergency room for evaluation of nightly fevers. So at this point, he's presenting with 1 week of nightly fevers as high as 101 and 102. He has a dry cough, no improvements of his fevers with Tylenol. He has a history of chronic back pain, but has no other symptoms. His past medical history is notable for chronic lower back pain. He had a lumbar decompression and fusion and a follow-up discectomy and a spinal cord stimulator placed 3 years ago, and he undergoes regular spinal steroid injections. The last one was several months ago. He has a history of low-grade papillary urothelial carcinoma. He had a TURPT and intravesicular BCG. He had with subsequent recurrence. He has had no treatment for several years at this point. He had an MI 27 years ago with TPA lysis and a stent placement. Bare metal stent was placed 21 years ago. He has sick sinus syndrome with a dual chamber ICD. Otherwise, he has hyperlipidemia, hypertension, chronic kidney disease 3, OSA, for which he wears a CPAP. He is a retired police officer, a former smoker with a 30-pack-year history. He is an occasional drinker, and he traveled to Central America 3 months prior to presentation. When we saw him in the emergency room, his Tmax, his temperature was 103.2, heart rate 75, blood pressure 127/61, respiratory rate of 18, satting 96 on room air. The exam, I know this is very lame, but the exam was documented as completely normal at that time. Labs were notable for a white blood cell count of 6.1, hemoglobin 11.4 grams per deciliter. His BUN was 17. His creatinine is 1.4, which is his baseline. ALT was 140. AST was 109. ALP is 136. T-Billy 0.9. His ProCal is 0.12. Just so you know, that is a send-out lab. So that took like over a week to return. That was elevated. He was COVID negative, flu negative, anaplasma, IgG, IgM negative, and he had 1 band positive on his Lyme screen, which was negative. This case was in 2020, for what it's worth. Dr. Del Rio, what are your thoughts? And I'm happy to go back.
Thank you, Adam. Well, trying to summarize this is as you said, a sort of elderly individual who's presenting with symptoms of chronic back pain and fevers, and he has some dry cough and he has a very interesting history, right? Having undergone a decompression and fusion, having a discectomy, having a spinal cord stimulator, and having, regular injections of steroids. All of those kind of, make me suspicious of, as Willie Sutton say, go where the money is, right? You think about where things are happening, what the action is. He's got many other things happening there that I think for the time being I'm going to ignore. But I would say for the first thing I would think about is you can approach this in several ways, and I would approach it first as a fever, right? So he's got a 1 week history of fever, so he's not yet an FUO. He hasn't had fever for 3 weeks, so you can go down the FUO pathway. But if we wait long enough, you will be able to go down the FUO pathway. But we got to remember that FUO pathway is defined as having a temperature over 38.3 on several occasions over more than 3 weeks with an uncertain diagnosis, or it used to be 3 weeks in the hospital. Now we never do that. It's just 3 office visits. It's kind of like 3 strikes and you're out, right? But you got to think about then this. So he's got fever, and you got to think about this is a retired police officer, and you have to think about what exposures he could have had working in law enforcement. Did he have contact with detainees? Was he in contact with shelters, bites, needle sticks, TB exposure? So you got to go, or you got to do what we in ID do, which is really try to get an epidemiological history that will orient you. So I want to hear about pets. I want to hear about travel. I want to hear about exposures. I want to hear where he's from, where he's been to, what people he's been in contact with, what kind of job that he did as a police officer, and trying to use that in trying to think further into my differential, and then I obviously worry about the paraspinal infection. I always think about what's really bad, what could really badly be going on here. And one of the bad diagnoses would be a spine or paraspinal infection. And you think about an epidural abscess, a vertebral osteomyelitis with discitis, a paraspinal abscess, or something related to his stimulator. And he's got risk factors for that. He's got a prior history, his age, and he's got repeated steroid infections. And so putting all those things together, I think, I would think about several things at this point in time. I would think number one is could this be, think about TB, think about fever, cough, low back pain. I think TB would be one diagnosis that would bring all those things together in my mind. The dry cough, the nighttime fevers are pretty classic for TB. You add that, does he have Pott's disease? So TB would be one diagnosis that I will pursue with testing in a variety of ways. And I would like to get sputum AFBs. I would like to get a quantiferon and do that. The second one is, always a 76-year-old presented with fever. I'd like to look at his mouth, see what his teeth look like, etc., what his prostate is like. But endocarditis is always a diagnosis that I worry, that I fear. And in this case, I would think, enterococcal endocarditis is the one I worry about, but I worry about streptococcal endocarditis and other endocarditis. And again, my exam, I would look for a murmur. I would look for for stigmata of endocarditis. And then, as I mentioned, with the spinal steroid injections in 2020, I would worry about a fungal infection. There was an outbreak of fungal infections related to steroid injection, and going back to 2020, about this may be around the time that this all happened.
This was that time. It was
So
high on our
I would
thoughts.
really worry about that as a possibility. And then finally, I'm going to think about, because of his age, about malignancy-associated infections. And the ones that I always think when you see a malignancy-associated infection is lymphomas, right? So I think my differential would be, tuberculosis, endocarditis, lymphomas, spinal osteomyelitis, primarily a fungal osteomyelitis related to the steroids. And I would begin my physical exam looking at those different things, and I will direct my diagnostic testing in that direction.
Well, I'm going to give you some diagnostic tests right now. So he had a CTA of his chest, no PE, chronic fractures of the 9th and 10th ribs. He had a CT abdomen pelvis, end plate irregularity with mixed lucency and sclerosis at T12L1, which appears new compared to a CT from 15 months prior. Nodularity of the bladder base, which may reflect indentation from enlarged prostate versus bladder lesion. He had prostanomegaly and mild splenomegaly. It was 14 centimeters. You can see that we were desperate because there was a tagged white blood cell scan, which was normal. He ended up having a TTE, EF 40 to 45%. Pacemaker wire was in place, no valvular pathology, no pericardial effusion. He had a CT sinus with a mucus retention cysts, and he had a mucus retention cyst and a polyp within the sinus right greater than left. Any questions on this before I go over what happened next? Or does this update your thinking, Dr. Del Rio?
Yeah, I mean, again, the TTE is not perfect. It's not a TE, but I will review the TTE with the cardiologist, and they really took it. They could see the valves very well. I think this kind of brings down in my differential diagnosis the possibility of endocarditis. Uh, I would still like to see a little more to rule out TB. I don't see even though the chest CT chest doesn't show anything there, I would love to see a quantiferon. Quantiferon doesn't diagnose TB, but at least talks you about exposure and getting some. And then, it is an in-play irregularity with lucency and sclerosis of the T12L1 that appears new compared to the previous CT that I worry about. And again, you got to go where the money is. So I'm focusing more on the possibility of a lesion in the spine causing what's going on. And I would be fairly aggressive as trying to get tissue and trying to make a diagnosis there.
All right. So some of the data that I think you would enjoy. So I will say that my trouble putting this case together is that this played from inpatient and outpatient over many months. He did have negative AFBs, I should add. He was admitted and started on broad spectrum antibiotics with no improvement in his fevers. Blood cultures were negative during that hospitalization. He had continued elevation in his transaminases. He was medically stable and he was discharged with a plan to follow up with urology. At home, he continued to have fevers, including as high as 103 when he followed up with his PCP. His outpatient PCP his outpatient ID doctor ordered a PET CT, which showed diffuse ground glass opacities bilaterally in the mid and lower lung, which were FDG avid, but there was no focal mass or focal infiltration consolidation and no FDG avid adenopathy. He was admitted just 2 weeks later, so he only went about 3 weeks out of the hospital. At this point, he had a much worse cough and he had lost 20 pounds. And at that point, he was noted to have cyanosis of his hands, knees, and legs. So again, he was started on broad spectrum antibiotics for like 2 days, which were stopped. CBC was unchanged. BMP now had worsening kidney function. So his baseline creatinine is 1.4. It is 1.8 now. His LFTs are considerably worse, 167, 292. Alk phos 543. His LDH is now elevated to 293. Calcium 9.4. Ferritin is now elevated at 218. His CRP is 70. CK20. Hep B was negative, Hep C negative, EBV, IgG, IgM negative, CMV negative, HIV negative, Babesia negative, Quant Gold negative, beta D glucan negative, parasite smear negative, Q fever negative, Bartonella negative, T Whipple negative. You can see ID doctors were involved. Antimitochondrial antibody negative, anti-smooth muscle antibody negative, ANCA negative, ANA positive at just 1 to 140. C3 and C4 were normal, TTGA normal, cryos were negative, SPEP, UPEP were normal, and the free kappa lambda was 84.7, 68.3. So that elevated with a little bit elevated of a ratio. Blood cultures ×3 were negative, and 1 fungal blood culture was no growth. The sputum NAT was negative, and there were AFBs cooking at this point, and then UA was normal. Yeah, go for it.
So a couple, if you go back in there, first of all, I think this, we many times start people on antibiotics empirically, and I'm glad they were only stopped after 2 days. But you got to remember that antibiotics are not antipyretics, right? And there was no infection they were treating. So broad spectrum, I don't know what it means, but obviously, we not uncommonly do that. But I commend the team that after 2 days said, let's stop this, because I would have liked to see, again, the echo was negative, but I would have liked to see 3 sets of blood cultures to absolutely rule out infective endocarditis before antibiotics were given. I'm glad that the workup for TB appears to be much lower in the differential right now, given what you see in the NATs and everything else. Go to the next page. Go to the next slide. Yeah, I am concerned here that a lot of things are happening. This patient is getting worse and getting worse quickly, right? His renal function is deteriorated. Not only his transaminases, but the alk phos is way out of proportion. I don't see a Billy, but this is suggesting that he's got some sort of
Oh, the Billy
granulomatous.
was normal. Sorry, I compressed. Billy
Yeah.
is normal.
So this suggests he's having a granulomatous hepatitis, and I worry about when I see granulomatous hepatitis is the differential changes. So again, lymphoma in my mind is starting to go up. I would love to see an RPR in this guy, make sure we're not missing syphilis, but obviously lymphoma is going up in my mind. And then the other things that you show here is basically he's got this very high CRP, high ferritin, so a lot of inflammatory markers. Which makes the possibility of inflammation, chronic inflammation, infection, malignancy, a possibility. Yeah, there's a lot of things that are negative that we as ID docs would have ordered, including babesia and other things, Bartonella. I'm glad they're here. I'm glad they're negative. We could have gone into the Whipple's disease differential. This doesn't sound like Whipple's, but again, it's always something fun to consider in a CPC, and I'm glad the tests are negative at this point in time. So my major concern right now would be around whether this is a hematologic malignancy like a lymphoma with those findings in the UPEP, and whether we need to go next to a bone marrow exam or some sort of lymph node biopsy, or again, whether something is going on in his back and we need to get some tissue from there.
Perfect. So some additional imaging. The CT head was normal. A repeat CT thorax showed end plate erosion unchanged, but several new lung nodules up to 4 millimeters. L5S1 hardware was still in place. He had a soft tissue ultrasound near the spinal stimulator to try to look. There was no fluid collection near the spinal stimulator, and a temporal artery ultrasound was normal. Dr. Del Rio, before I tell you what happened next, any questions?
Well, yeah, I mean, I'm concerned about those new long nodules, and I would like to see, they're 4 millimeters. Are they central? Are they peripheral? Are they associated with what's their
Yes.
their density?
They are peripheral lung nodules. Yes, they are relatively small but new peripheral lung nodules.
Yeah. So, is he throwing emboli, right? Is he embolizing? Does he have some sort of endovascular lesion? Does he have uh, he is seeding his lung with either infection or malignancy. And again, whether that's one of the lesions you want to biopsy, that's the other thing I would think about. So TB malignancy continued to be high in my differential.
Perfect. And now, unfortunately, what happened, so I was caring for the patient during this hospitalization. He rapidly worsened overnight, ended up getting intubated and on 2 pressors in the ICU, and his family withdrew care shortly thereafter, and he passed. So we did not have a working diagnosis during the hospitalization.
But this is obviously then when I think, we rarely do autopsies nowadays, but this is the kind of situation where you really want to get an autopsy, right? Because I think you feel frustrated, the family's frustrated, and I think trying to get an answer is going to be important for the team and the family.
Perfect. Are you ready, Dr. Del Rio? Do you have any other comments before I give the same information to our AI system and have Dr. Cabot walk through this?
No, let's have Dr. Cabot tell us what he thinks or she thinks.
She thinks. I'm not sure the gender of Dr. Cabot. Can everybody see this? Yes?
Yes.
Good morning, everyone. Thanks for joining our noon conference. I'm Dr. Cabot, and I think you'll agree this case takes us on quite a diagnostic roller coaster. We'll, walk through the patient's story, unpack the data, and see how a single detail ends up changing everything. So, starting with the background, this gentleman is 76, retired Boston police, and he comes with a suitcase full of comorbidities: degenerative lumbar disease with hardware, bladder cancer treated repeatedly with intravesical BCG, ischemic cardiomyopathy with an ICD, and the usual hypertension, CKD, and so on. Socially, he lives with his wife and a cat, quit smoking years ago, and, he enjoys the occasional Caribbean cruise. Let's zoom in on the timeline because the tempo really matters. About 9 weeks ago, he develops nightly fevers and a dry cough. He's hospitalized, drenched with broad-spectrum antibiotics, nothing grows. 4 weeks later, the PET shows those FDG avid ground glass opacities and, interestingly, an erosion at T12L1. By week 8, the fevers keep coming, weight has melted off, and confusion brings him back to the ED. That's the admission we'll dissect today. On exam, well, there's honestly not much. He's hot, 103, and tired, but he's hemodynamically stable, lungs are clear, heart sounds fine, abdomen soft, and no rash or joint swelling. That relative paucity of findings kind of sets the stage for a fever of unknown origin framework. Here are the first admission labs. WBC is normal, but there's a spicy 15% band count. Transaminases are up, ALT 140, AST 109, and alkaline phosphatase modestly elevated. Procalcitonin basically flat, ESR only 13. That low inflammatory signature is, a bit atypical for run-of-the-mill bacterial sepsis. Fast forward to admission number 3. Platelets have drifted down to 132, creatinine bumped to 1.8, and look at the liver numbers. ALT 167, AST almost 300, ALK Phos 543, albumin 2.7. CRP has climbed to 70, but still not the 3-digit monster we'd expect with pyogenic infection. It's telling us something inflammatory, yet smoldering. Initial imaging, CTA chest shows no clot. Abdomen CT whispers new end plate irregularity at T12L1 and a touch of splenomegaly. Nuclear WBC scan, that negative scan makes aggressive pyogenic osteomyelitis less compelling. Later images raise the stakes. PET CT lights up both lungs with diffuse FDG avid ground glass, SUV about 3.8, but no nodes. A month later, CT thorax shows the spinal erosion extending to T11, T12, and a smattering of tiny pulmonary nodules. Temporal artery US is stone cold normal. All right, let me crystallize the problem. A 76-year-old man, nightly fevers for 2 months, dry cough, 20-pound weight loss, cholestatic hepatitis, mild thrombocytopenia, and evolving thoracolumbar end plate destruction, plus diffuse FDG avid ground glass opacities, despite antibiotics and negative cultures. Big infectious bucket first. We've got pyogenic spinal infection, culture-negative endocarditis, zoonoses like brucellosis or Q fever, fungal or mycobacterial processes, and we mustn't forget disseminated BCG, given the bladder cancer history. Non-infectious contenders, Hodgkin lymphoma, metastatic bladder cancer, adult-onset stills, systemic vasculitis, maybe sarcoidosis. None perfectly match, but we keep them on the board early. So, pyogenic spondylitis. The spine CT certainly looks worrisome, but blood cultures are persistently sterile, ESR is low, WBC scan negative, and crucially, it doesn't explain the lung or liver story. So I'm backing away from staff and friends. How about endocarditis or a zoonosis? ICD wires are attempting nidus, but TTE is clean and serologies for Coxiella, Bartonella, Brucella all negative. No embolic skin or eye findings. Caribbean travel, yeah, but no unpasteurized cheese binges. Probability sliding down. Now here's where it gets interesting. Intravesical BCG. The patient had multiple courses over 4 years. Disseminated BCG infection presents with high spiking fevers, pneumonitis manifesting as ground glass change, cholestatic hepatitis, and yes, thoracic or upper lumbar osteomyelitis. Quantiferon can be falsely negative, routine cultures miss it, and cefepime actually has a little antimycobacterial activity, explaining those transient defervescences. Everything snaps into place. Putting it together, the most likely diagnosis is disseminated Mycobacterium bovis BCG infection, causing vertebral osteomyelitis, pneumonitis, and granulomatous hepatitis. Next steps, we need tissue. A CT-guided biopsy of that T11, T12 disc space for AFB stain, mycobacterial culture, and M. bovis PCR is the money move. If that's non-diagnostic, a liver biopsy is a reasonable fallback. Once specimens are collected, we'd start 4-drug therapy, rifampin, isoniazid, ethambutol, plus pyridoxine, monitoring vision and hearing along the way. Key takeaways. First, remember that intravesical BCG can bite back, even years later. Second, the triad of fever, pneumonitis, and cholestatic hepatitis should ring a bell. Third, vertebral osteomyelitis from BCG favors the thoracic lumbar end plates. Fourth, routine cultures and quantiferon can be falsely reassuring. Finally, early suspicion and tissue PCR get your patient treated before irreversible damage sets in. Thanks, everyone, for your attention. Happy to discuss or take questions.
Okay, well, here, I'll stop sharing for a second. Dr. Del Rio, what did you think?
Yeah, I think it's a pretty good differential, and I think something worth considering. Looking at the history, obviously the BCG exposure is something always that we tend to forget sometimes, and I think that's a disseminated BCGiosis is always a consideration. So it fits again, but goes back to really the importance of getting tissue early in a patient like this, because when he was discharged initially, had biopsy been done, maybe this ultimate, unfortunate outcome would have been avoided.
Yeah, and so what ended up happening is he passed. He passed actually within 24 hours of transferring to the ICU. We did get an autopsy. So his he was well known to us. We knew his family. We got an autopsy, tissue samples were sent, and about 6 weeks later from the state lab, we heard back that it was M. bovis. So it was, in fact, BCG emia. And it was actually quite shocking to everybody because obviously something that we had thought on our differential, but we had assumed that this was infected spinal hardware all along.
Yeah. Yeah, I mean, I think that's a challenge, right? When you have somebody who's sick and with a lot of, as Dr. Cabot said, a big suitcase full of past history and distractors, they pull you in different directions, right?
Yeah, and that's what happened in this case. We were pulled in a, you could tell from the tests and the consultants, we were pulled, we considered spinal infection, endocarditis, tuberculosis, and then hematologic malignancy, which is where the plans were to
Yeah.
work up more when he decompensated and passed.
Yeah, absolutely. No, I think it's a very illustrative case, and I think those very challenging cases that we all have when we are taking care of of a of a critically ill patient like this one.
Well, thank you so much, Dr. Del Rio, for for putting yourself up there to do that. Fantastic.
No, that was fun. Enjoy talking to you.
Well, for everybody else, actually, Annie, are you still here?
Absolutely.
Do you want me to keep talking some about human-computer interaction, or should we go into questions or reflections from the audience? What do you think would be a best use of time? I'm up
Um,
for everything. Adam can talk forever.
maybe like 5-10 minutes of
Okay,
computer interactions, and then we'll have like 5 to 10 minutes for Q&A.
perfect. So I'll go for about 5 more minutes relatively quickly, and then we'll take some questions. Okay. You can see my screen, right? I'm apparently forgetting how to use a computer, which is very embarrassing. Okay, so one of the things that is really so we touched on this at the beginning. So LLMs are capable with these reasoning models of having human-like decisions. Now, that doesn't inherently matter. One of the truisms of like decision support, clinical decision support, is that high-performing AI systems don't always actually improve human performance. There's many reasons for this. We can go into detail if you want. And this is not something new, right? We've known this since the 1970s in medicine. Tim DeDombal very famously was the guy who came up with the name clinical decision support. So we've known for a long time that high-performing AI systems don't necessarily translate into the real world, into real-world performance, because people have to use them. What is different about LLMs in particular is that they are able to collect within limited domains their old information. This is where I'm going to talk about some of my Google work. So we trained an AI model almost 2.5, 3 years ago. This was published in Nature to take histories and tested it on standardized patients, not real patients, but in a blinded Turing test through a very artificial framework via a text-based framework back and forth. The LLM had equivalent or better diagnostic accuracy to humans. We saw something very similar with management decisions. Then we ran a really cool experiment where we wanted to do guardrails, right? You let the AI take a history, don't give any medical advice at all, and see if it can do it. And effectively, we found that the AI system is able to do that in a meaningful fashion. Check the news on March 11th. So I finished running a clinical trial, the first ever pre-registered patient-facing AI clinical trial in a real clinical workflow in my clinic at Beth Israel. It is going to be published on March 11th. So we just wrapped up an actual study of patients presenting for urgent care at my clinic. And we found the exact same thing in the real world. The systems are able to have high diagnostic accuracy, very safe. Patients really liked it, and they're able to communicate to those patients PCP in a meaningful fashion. So what is a little bit different about older types of clinical decision support is LLMs within limited domains are able to directly interact with our patients. Now, why does this matter? Currently, so I know this says autonomous weapon systems. All of the language we use to talk about the regulatory space for patient-facing AI comes from autonomous weapon systems, which I don't like that. The same language we use to talk about killing people, we use to talk about saving people's lives. Nonetheless, this is the regulatory language we have. So human in the loop systems are like what you guys have when you use an AI scribe or open evidence. A human needs to read and verify every single piece of the information. That is a human in the loop system. Virtually every single AI system, medical AI system out there, the exception might be Doctronic, which we talked about doing the prescription refills. Hippocratic AI, this uses like more nursing tasks rather than doctor tasks. But Hippocratic AI also has a human on the loop system. A human on the loop system is when an AI system acts autonomously, but always passes back to a human to either supervise or to make certain high risk decisions. So the AI is allowed to work autonomously in some domains, with humans always supervising and human pass off for high stakes decisions. A human out of the loop is no one serious is talking about this. These are fully autonomous AI systems. There are very many reasons to think that human in the loop is not going to work out in the long run. The first reason is humans, if a human has to verify AI outputs, it doesn't scale. This is what we've seen with the AI scribe literature. Patients like scribes, doctors like scribes. They don't save any money and they don't really save any time. Why? Because the human, you, me, has to go through, read the note, make sure everything is okay. Number two is automation bias. Automation bias, the example I always give is that episode of The Office when Michael Scott drives into a pond because he misinterprets what the GPS tells him. Automation bias is our tendency to basically turn our brains off when we have a high-performing AI system. Automation bias is a real big threat to human in-the-loop systems because we turn our vigilance down. And then finally, there's cognitive de-skilling, which is the tendency for humans in high-performing systems to lose some of their skills. This is a big concern, and I won't talk about this right now, but a big concern in medical education, where it's less cognitive de-skilling and more never skilling when it comes to high-performing systems. So, what I will say, just to close this out before questions, like if I'm looking at what my lab is working on, what I'm doing also at Google, and some of the work I'm doing for the government, there are huge, like regardless of what you hear from the startup world, there are huge challenges for a future world in which human physicians and AI work together. The first is that it's actually really, really hard to get AI systems to understand health data. There is a reason that Dr. Cabot works very well over like a 4-page, if I've written out and copied all the things, it's very hard to get them to work over unstructured data. Diagnosis, these systems are incredibly good at, largely because of reinforcement learning. Management reason is a major challenge. This is some cool work from my lab that basically shows that management reasoning, even the models have gotten really good at not making explicitly dangerous decisions, but there'll be a trade-off where they won't make decisions, they'll omit things. So management reasoning is really, really complicated. And I don't know that large language models are ever going to, I shouldn't say ever, are going to solve this anytime soon. So we're in this strange paradox now where diagnostic abilities are probably superhuman for a lot of medical tasks, but management, including very basic management, is something that humans do much, much better. There's no regulatory framework. I spoke a little at the beginning about how ARPA-H is trying to fund new regulatory frameworks. And then even if there were a regulatory framework, there is not a proven technology that is capable of safely monitoring these systems. And then, of course, there's a paucity of clinical trials. I have a clinical trial coming out. I'm very proud of it. I think it shows the safety, but there are no trials that are powered to show what we care about in medicine, which is actual outcomes on our patient. So that is it. I will take, I think I managed to do that in 5 minutes, and I can't believe that we got through all that. So
that was incredible. Thank you so much for that amazing talk, Adam. And we do have one question already in the chat. Could the corticosteroid shots given repeatedly predispose to the disseminated mycobacterial infection?
that's a Dr. Del Rio question, not an
I
Adam
think
question.
that's unlikely. The major risk factors for BCGiosis are, for example, severe immune suppression, let's say HIV, and also the certain inborn errors of immunity. When you have mutations that impair interferon gamma or interleukin pathways, you tend to have disseminated BCGiosis. In the treatment of bladder cancer, really the major risk factors for disseminated BCGiosis is the dose used in the installation and the and traumatic catheterization, that produces breaks in the mucosa that leads to invasion into the bloodstream. But but I'm not aware of steroids being a risk factor. So I would say there, no, again, that's another red herring that took us in a different direction.
Michael Chung. Oh, that's right. Here, let me unmute you.
Oh, right. Oh, no one else can talk, right?
Yes.
Sorry.
Thank you. And thank you, Dr. Rodman, for a great talk. One question I have in reading a science article or what I remember of that 10 years ago about chess and AI's ability to sort of do so much better than anybody else is that it was so good that it wasn't able to explain how it made the right answer. And it was just doing it in that way that it just came up with the right answer. But because of that, wasn't able to give a theorem of, oh, this should be a Roy Lopez or a Queen's Gambit or something like this. So then wasn't able to teach people then how to even reproduce its good results. So I'm curious with this in large language modeling and clinical, are we also in a situation where it may just come up with an answer and not be able to teach us then how to get there? I'm curious what your thoughts are about that.
Oh, so the answer is yes. And so first, everybody read this paper when it comes out on March 11th, because we actually tested this theory. So Dr. Chung, just to tell you this experiment. So I had an AI system talk to all of our urgent care patients who came in. And one of the cool things is that we adjudicated the final diagnoses from the chart, but we have the reasoning chains. So we're able to ask the model. It's like AI metacognition. You can basically, unlike a human, you can replay its thinking and at any set say, what are you thinking? So I know all the intermediate steps it made. And what we found is that the model confidence is not at all correlated with its performance, meaning it explains its thoughts brilliantly, whether or not it's right or wrong. So to your point, LLMs and diagnostic ability is much more similar to Deep Blue playing chess than you would think. Deep Blue is a constrained field. LLMs are, I mean, it's a constrained field, but like it's so many trillions of parameters, there's no way to know. But a lot of the interpretability, when people talk about interpretability from these recent traces, is pseudo interpretability. So you can read it. It might influence a human, but it might influence a human in a wrong way because the explanation itself is wrong. This is a huge challenge when it comes to like people are working on this. Very smart people are working on this. But right now, like Dr. Chung, you're 100% right. You could look at these brilliant traces and I can objectively show you that it is just as convincing when it is right or when it is wrong.
That is very interesting and also terrifying.
Yes, it's terrifying that BS can sound like it's true, right?
Well, you know, when I saw this, the Google engineers were like, Adam, does this make sense? And I was like, guys, I got excited because this is the same phenomenon that we've seen in some of like Sylvia Mahmood's experimental studies with humans. Human doctors can't quantify their uncertainty. They have no idea. And it's so funny. Their uncertainty will also decrease as the case goes through just because it's going through. So I saw this and it's actually very discouraging because like ideally you want biases to go in different directions, right? You want the LLMs to not be like us, but like part of me is like, how did we create this thing that shows the same phenomenon that we see in human experimental studies?
Fascinating.
Yeah. What other questions y'all have?
So, Adam, give us like a 3-minute. What do you think we're going to be 5, 10 years from now? How are this thing's going to be incorporated into, into how we work regularly? Because right now, we're just beginning to test the cell phone, but I still think that we have the cell phone that used to be like a brick, right?
Do you want me to give you the optimistic view that I'm pushing for, or do you want me to give you what I'm worried about might happen? The worst case scenario.
I want to be optimistic. I need something positive.
Okay. So in an optimistic scenario, we have a system where I'll co-locate myself in primary care. So me as a primary care doctor, I prescribe to my patient or give my patient an AI agent that can do tasks for me. And this would mean, for example, my patient has hypertension, check in with my patient, counsel them, see how their blood pressures are, recommend by passing back to me if they need modifications in their meds. Also, something that they can talk to 24/7, but the same system will know when to pass back to me. So the ideal world is what I would call triadic care, where there's still a fundamental relationship between the doctor and the patient, but the doctor's role and trust is extended by AI agents that are accountable and reportable to the doctor, but nonetheless patient-facing. That is what the federal government is trying to do via ARPA, via these funding mechanisms. And that is what I am very hopeful for, is that this technology will free doctors to some extent from a lot of the administrative views and also expand our contacts and care for our patients. So that's the good view.
Yeah, I would only add to that, if this system can also do the pre-authorizations, we would be in heaven.
Yeah, I see Shub Agrawal is bringing on the dark side. So Shub, this is the dark view. So one of the things that is almost certainly going to be true is that the systems will surpass us, and they probably have surpassed us in diagnostic abilities, and they will probably surpass us in some other abilities. If we do not come up with another regulatory system, everybody knows what's going to happen. Instead of seeing 12 patients, 14 patients in clinic, I'm now going to see 25 patients in clinic. And my job will be to click yes on the computer output so that I can be sued when something goes wrong. So I think that we should not have a naive assumption that things will go well. It's like the EHR. And I worry that in the absence of us, I think doctors need to advocate for ourselves and our patients. In the absence of being creative about new care and interaction models, if we just use our existing interaction model, it's going to be like a dark place where the job of a doctor, it's called a moral crumple zone. The job is for us to accept AI outputs so we can be sued.
Looks like there's a question from the Midtown
We had a
residents.
question actually before that. What should internists be doing now to prepare ourselves for what's coming? No pressure.
No pressure. What I would say is the skills that are going to make us succeed in the future are the skills that have always been really important, which is honing our thinking abilities, honing our ability to build relationships and trust with our patients. Being a doctor has been a task, a career, a calling for thousands of years. And I think that if we look at what made the Hippocratics physicians, if we look at made Osler a great physician, and look what us makes a great physician, it's the same thing. So keep doing what you're doing. This is a new technology. It is probably an epistemic technology, but medicine is still medicine.
From an equity perspective, how is AI going to be used to address affordability, patient confidentiality, and mistrust in institutions?
Great questions. I can tell you what the hope is. I don't know if it'll be true. One of the big hopes from regulators, and this is not just in the US, this is all over the world, is that AI, patient-facing AI, will drastically expand access at lower cost. So there are many places in the country where people do not have, I mean, Boston is one of them, where people do not have access to primary care doctors, even more places where there are gaps in specialty care. So some of the government's interest is from an access and equity issue. Now, this is very interesting when you say about confidentiality and mistrust in institutions, because people do not like AI. There is a lot of mistrust towards artificial intelligence. And like this company, Lotus, like saying they'll have a AI doctor, would you trust them? For the record, I don't trust, no one should use ChatGPT for health. Do not give OpenAI access to your health records. So the question about trust of patient-facing AI systems is, yes, a question about a technology, but we don't inherently trust the technology. It's a question about us as doctors and the systems that we have. So in a lot of the qualitative research, and including in my own trial, everyone was super skeptical until they tried it, and then until they saw that their doctor was talking to the AI, and then the trust levels almost doubled. So I think the impetus is on us as clinicians to make it clear that these are systems that are extensions of us, that their data is handled in good ways, and to have these things as part of our healthcare tools. As long as we have that trust will extend to our tools. That is why we cannot, this is why the die is cast. I think physicians have a moral imperative to engage with this, because the alternative is tech companies creating these very dangerous direct-to-consumer platforms that cut us out of it.
How do you see AI assisting with behavior change and following healthcare recommendations? We sometimes know the right thing to do, but face multiple barriers in having patients do those recommendations.
So again, there are regulators in DC who think that AI as a health coach will make a big difference. I think all of us know the challenges. There is knowing and then implementing, and I will put myself on the more skeptical side to what degree an AI agent reminding you to eat healthy will. I'm sure it will help for a certain subset of people. I think it is more likely to help in people who already have disease. So managing hypertension, helping to manage diabetes. I don't know. I'll just say I'm skeptical to what degree it will help in those coaching scenarios. I would love if it would. I know some people have good experiences, but nothing in the literature would make me think that that's going to make a big difference.
Thank you, Adam.
All right. Thanks, y'all. We are at time. Thank you, Adam. This was an incredible talk. I look forward to seeing you in Nashville in a few months. And thanks, everyone else. Have a great rest of your afternoon.
Yeah. And thank you, Dr. Del Rio. That was a lot of fun. Great job.
I enjoyed it. Take care.
All right. Bye, y'all.
Thanks, Annie.